So, hello everyone. Thank you for joining the meeting today. We're going to start, and Dr. Maarib will moderate the meeting today. So, thank you. So, hello everyone. Thank you. Go ahead, Dr. Maarib.
Hello, Dr. Nadir, and hello everyone. I hope you're doing well. And today's meeting will be presented by us, the Yellow Group. Should we start right now, Dr. Nadir, or should we wait?
If your team, at least one of them is ready, we can start. If in the group.
Yeah, I think we're ready. So we will start it with the first topic, which is hematology in older adults, and it will be presented by Dr. Amna Elkhidir and Dr. Samah Ahmed. So go ahead, please, Samah and Amna. Samah and Amna, are you here?
Hello.
Hello, Dr. Amna.
Hello.
Yeah. Good evening, everyone.
Good evening.
Can you hear me well?
Yes.
Okay, can I start now?
Yeah, please.
Okay. Okay, today I'm going to present anemia, platelet, and clotting disorders. First, I'm going to talk about anemia. It's most common age-related hematological abnormality. According to WHO, the diagnosis of anemia is usually present when the hemoglobin is less than 12 in women or less than 13 in men. Older adults have a high prevalence of anemia. In people aged more than 65 years, 10.2% of women and 11% of men has anemia. And more than 80 years old, 12 to 16% of women and 18 to 22% of men have anemia. Usually, the exact etiology is often unexplained despite appropriate evaluation. Classification of anemia is classified according to the cause of anemia into 3 categories. First one is impaired production. The second one is increased degradation, and the third one is due to blood loss. I'm going to talk a little bit about the first class of anemia, which is impaired production. Is subdivided into 2 categories: disturbance of proliferation and differentiation of stem cells, and disturbance of proliferation and maturation of erythroblast. The disturbance and differentiation of stem cells, example of anemia are pure red cell aplasia, aplastic anemia, Fanconi anemia, and anemia of kidney failure. And when there is disturbance in maturation of erythroblast, the anemias examples are pernicious anemia, which is vitamin B12 anemia due to intrinsic factor antibodies against the parietal cells of the stomach lead to decreased absorption, and anemia of folate deficiency, anemia of prematurity, and iron deficiency anemia. Also thalassemia and anemia of kidney failure. The kidney failure usually cause both types of anemias, differentiation of stem cells and maturation of erythroblast. Myelocytic anemia, it's a severe anemia due to replacement of bone marrow by other materials, for example, tumors. and also anemia of chronic inflammation. All these lead to decreased proliferation of RBCs. Second type of anemia is increased destruction due to intrinsic abnormalities and extrinsic abnormalities. Example of intrinsic abnormalities causes premature destruction, like hereditary spherocytosis, elliptocytosis, and A-beta lipoproteinemia. These three types of anemia due to abnormal membrane of RBCs lead to destruction. So the problem is inside the RBCs. Second one is enzyme deficiencies like pyruvate kinase and hexokinase deficiencies. These two causes decreased glycolysis and apoptosis. Because 6-phosphate dehydrogenase deficiency and glutathione synthetase deficiency, this leads to increased oxidative stress on the cells, and thus the cells dies eventually. Hemoglobinosis like sickle cell anemia and paroxysmal nocturnal hemoglobinuria. The extrinsic abnormalities like antibody-mediated warm autoimmune hemolytic anemia. These types of anemia are treated by steroids and splenectomy. Also, the damage can be due to mechanical trauma to red blood cells, like on artificial valves. I'm sorry. And also, third type is called autoimmune hemolytic anemia. The autoimmune hemolysis is often frequently associated with lymphoproliferative disorders. When patient usually has autoimmune hemolysis, this makes us suspect that he have also other lymphoproliferative disorders like non-Hodgkin lymphoma or chronic CLL. The third type, blood loss. The typical finding in anemia from blood loss, there is decreased iron and decreased ferritin, and high total iron binding capacity, reflecting absent iron stores. So it's look like iron deficiency anemia. Examples like loss due to gastritis from medications, due to angiodysplasia, benign tumors. Usually GIT tumors are most common tumors that cause blood loss. The impact of anemia is elderly is particularly relevant as it has a number of serious consequences. It has associated with higher incidence of cardiovascular disease, because usually anemia causes there is increased cardiac output from anemia, so eventually it can cause heart failure. There is cognitive impairment symptoms. There is decreased physical performance due to symptoms of anemia, decreased quality of life, and increased risk of falls and fractures from dizziness. The most common causes of anemia in the elderly are nutritional deficiencies or anemia from chronic disease or unexplained anemia. Nutritional deficiencies like lack of iron, lack of vitamin B12 or folate. Anemia of chronic disease is usually multifactorial. It causes anemia by functional iron deficiency. There is enough iron in the body, but there is decreased utilization of iron. This is enhanced apoptosis of erythroid progenital cells in the bone marrow. And also there is inadequate production of erythropoietin and impaired response to erythropoietin. This is the mechanism by which chronic disease can cause anemia. The third type is unexplained anemia. It's almost 1/3 of all anemias in the elderly and represent primary diagnosis of exclusion. When we have usually anemia, we first perform physical examination to look for underlying disease which may be the cause of anemia, like renal or hepatic failure. And also we evaluate for GIT losses and genitourinary blood loss. When we found any of these, we treat the underlying cause first. Then we do CBC and look in indices, reticulocyte count, and we can do peripheral smear. Usually peripheral smears can suggest the cause, like hereditary spherocytosis, we find spherocytes in blood cells, in peripheral blood film, and like teardrops, when we have teardrops, RBCs usually is a cause in bone marrow failure. Also, we can find sickle cell in sickle cell anemia. like this. Then we look at reticulocyte index. If we found adequate response of reticulocyte, like reticulocyte index of 2 or more, so we suspect here blood loss or RBC's destruction. And when we found the reticulocyte index is less than 2, there is inadequate response, inadequate regeneration of RBCs. We look at the RBC indices. First, we look at MCV. If we find low MCV, we can consider renal disease, and we can check the serum ion, total ion binding capacity, ion saturation, and ferritin. Okay, when we found low ion, less than 60, and low total ion binding capacity, and low saturation, and increased ferritin, here we have anemia of chronic disease. Okay. When we found low ion and high total ion binding capacity, and low saturation and decreased ferritin, we have anemia, ion deficiency anemia. In between, we can suspect the ion deficiency anemia, but we can search for B12 and folic acid deficiency. And if these all are normal, we treat the patient as ion deficiency anemia. If no response to treatment, then we can go for bone marrow aspiration. So bone marrow aspiration is the last thing in the series of investigations. When we have high MCV, we can consider the cause to be alcohol if the patient is alcoholism, hypothyroidism, and hepatic disease. Then if all these are not the cause, we can check for B12 and folate levels. If we found low folate, this is a folate deficiency, we treat the patient with folic acid 2 mg daily. If we found low B12, this is the B12 deficiency, we treat with oral B12. Okay, if both have normal levels, we check for methylmalonic acid and homocysteine levels. Usually in B12 deficiency, we have high MMA. And in folate deficiency, we have high homocysteine. If both we found are normal, we do ion studies and ferritin levels. If the results are normal, anemia of unknown cause, we go for like the first one, we go for bone marrow biopsy, and we can do transfusion or trial of erythropoietin if anemia has no response. Also, platelet and white blood cell count can help distinguish an RBC problem from a broader underlying bone marrow process. In bone marrow diseases, we usually have affection on RBCs on platelet and white blood cells. Bone marrow biopsy is generally indicated after exhaustion of morphological and laboratory workup in the setting of more than or equal to abnormal cell lines. Also, we can do hemoglobin electrophoresis, for example, in sickle cell trait, in sickle cell disease. In sickle cell trait, we do genetic testing. Okay. Iron deficiency anemia is the second most common cause of anemia in elderly. It usually in elderly results from chronic GIT blood loss or inadequate intake or absorption of iron. Okay, the serum ferritin is the most effective way to diagnose iron deficiency anemia. We have low serum ferritin iron deficiency anemia. Iron deficiency anemia in the elderly almost always lead to evaluation of the GIT tract as the possible source of bleeding. It's diagnosed by the presence of decreased serum ion, decreased transferrin saturation, and normal or decreased serum ferritin concentration. And also considers the evaluation of blood loss from the genitourinary tract, GI tract, or female reproductive tract. We treat iron deficiency anemia by oral iron. The absorption of iron may be impaired by if there is decreased gastric acid secretions like achlorohydria, or from atrophic gastritis, or from pharmacological suppressions. We give, in these cases, we give usually iron with vitamin C to enhance iron absorption. The usual dose of elemental iron is 50 to 100 milligrams 3 times per day. Okay. Anemia of chronic disease. In anemia of chronic disease, we have normal to increased ferritin, we have low serum iron, we have low serum transferrin levels and iron saturation. The bone marrow in anemia of chronic disease show normal erythroid precursors with increased storage iron. Usually in anemia of chronic disease, we have normal iron stores, but we have functional iron utilizations. Consider measuring ESR or CRP as in the case of chronic disease ongoing.
I'm next, excuse me.
Yeah.
Yeah. If you are busy with the baby, you can settle her down. I will present and then you can continue, please.
Okay.
Okay. Okay, can you stop your share, please? Okay, so sorry, dear fellows. Me and Amna have the same topic. So I will continue this part, and after she settles down her baby, she can continue, please. So I will present the hematopoietic stem cells and aging. You can see my screen, please.
Yes.
Yes, we can see it.
Yeah, you can see.
Okay. So hematopoietic stem cells ensure a balanced production of all blood cells throughout life. As they age, hematopoietic stem cells gradually lose their self-renewal and regenerative potential, whereas the occurrence of cellular derailment strongly increases. So when I talk about hematopoietic stem cells, I mean RBCs, white BCs are platelet. So white blood cells can be macrophage, basophil, eosinophil, neutrophil, and lymphocyte. So hematopoietic stem cells have the potency for self-renewal. So the age-associated strategies to intervene in aspects of the stem cell aging process may have significant clinical relevance. So in the hematopoietic system, there are multiple indications that stem cells do not formally self-renew, or at least have a restricted self-renewal potential, and are therefore fundamentally different from pluripotent embryonic stem or the pluripotent stem cells. So the kind of damage that happens for the cells is usually related to the telomeres, which is this part of the chromosome. With age, it starts to stop its function, and accordingly, the renewal stops. So loss of immune function and an increased incidence of myeloid leukemia are the two of the most clinically significant consequences of aging of the hematopoietic system. So now I will talk about myeloid hematological malignancies. So hematological malignancies are cancers that affect the blood, bone marrow, and lymph node. This classification includes various types of leukemia: acute lymphocytic, which is ALL, chronic lymphocytic, CLL, acute myeloid, AML, chronic myeloid, CML, myeloma, and lymphoma, which is Hodgkin's and non-Hodgkin's lymphoma. With the exception of ALL and Hodgkin's lymphoma, the disease tends to be associated with increasing age. So leukemia is a type of cancer that affects white BCs. Leukemia can cause symptoms such as fatigue, weight loss, frequent infections, anemia, and bleeding or bruising easily. So the first of the myeloid leukemias is acute myeloid leukemia. AML is a fast-growing type of leukemia that involves myeloid cells. It usually affects cells that will eventually become white BCs, but it can also affect immature RBCs or platelets. And AML is the most common acute leukemia in adults. Regarding AML, males are affected more often than females, and the 5-year survival rate is about 35% in people under 60 years old and 10% in people over 60 years. So almost is a disease with a poor prognosis. The risk factors for AML include smoking, if the patient have previous chemotherapy or radiation therapy, myelodysplastic syndrome, and exposure to the chemical benzene. The symptoms may include feeling tired, shortness of breath, easy bruising and bleeding, and increased risk of infection. The diagnosis is generally based on bone marrow aspiration and specific blood tests. So the AML have different names. The condition also known by the following names: acute myelocytic leukemia, acute myelogenous leukemia, acute granulocytic leukemia, acute non-lymphocytic leukemia. The classification system includes these different AML groups. So we have AML with recurrent genetic abnormalities such as chromosomal changes, AML with myelodysplasia-related changes, therapy-related myeloid neoplasm, which may be caused by radiation or chemotherapy, AML, which is not otherwise specified, myeloid sarcoma, myeloid proliferations of Down syndrome, and acute leukemia of ambiguous lineage. So about the treatment, the main treatment for most types of AML is chemotherapy, and sometimes along with the target therapy drug. Target therapy is a new type of treatment for cancer patients. It's just targeted the cancer cell, so it approved recently, and it have a better effect and less side effects. So this might be followed by stem cell transplant. Other drug besides standard chemotherapy drug may be used to treat people with acute promyelocytic leukemia, which is APL. The surgery and radiation therapy are not a major treatments for AML, but they can be used in special circumstances. Then chronic myelogenous leukemia. So in CML, a genetic change takes place in an early or the immature version of myeloid cells, which is the cells that make RBCs, platelets, and most types of white BCs, except the lymphocyte. So at CML, it's not affecting lymphocyte. This change forms an abnormal gene called PCR-ABL, which turns the cell into a CML cell. So in the picture, this is a normal chromosome, normal chromosome 9, and normal chromosome 22. When its translocation happens, this is the outcome, will be the Philadelphia chromosome, which have a PCR and apple gene. Take apple from this part and PCR from this part. So CML is fairly slow-growing leukemia, but it can be changed into a fast-growing acute leukemia that is hard to treat. In chronic leukemia, the cells mature partly, but not completely. These cells may look fairly normal, but they are not. They generally don't fight infection as well as normal white BCs do. The leukemia cells also live longer than normal cells, build up and crowd out normal cells in the bone marrow. The chronic leukemias can take a long time before they cause problems, and most people can live for many years. But chronic leukemias are generally harder to cure in compared to the acute leukemia. So the symptoms is bone pain, easy bleeding, feeling full after eating a small amount of food, feeling run down or tired, fever, weight loss without trying, loss of appetite, pain or fullness below the ribs on the left side, excessive sweating during sleep, which is night sweats. The factors that increase the risk of chronic myelogenous leukemia is older age, being male, radiation exposure, such as radiation therapy for certain types of cancer. People with chronic phase CML generally have a very good prognosis, while accelerated or plus phase disease lead to worse outcomes. The phases of chronic myelogenous leukemia include chronic, accelerated, and plus. The chronic phase is the earliest phase and generally has the best response to treatment. Second, we have the accelerated. The accelerated phase is transitional phase when the disease becomes more aggressive. Plus phase is severe, aggressive phase that becomes life-threatening. About the diagnosis, tests and procedures used to diagnose chronic myelogenous leukemia include blood test. A complete blood count may reveal abnormal white BCs in the blood cell, such as a very high number of white BCs. So bone marrow test, bone marrow biopsy, and bone marrow aspiration are used to collect bone marrow samples for laboratory testing. And importantly, we do tests to look for the Philadelphia chromosome, which is the BCR Apple gene. About the treatment, the goal of chronic myelogenous leukemia treatment is to eliminate the blood cells that contain the abnormal BCR ABL gene that causes the overabundance of diseased blood cells. So for most people, treatment begins with targeted drugs that may help achieve a long-term remission of the disease. So the target of this drug is a protein produced by the BCR ABL gene, tyrosine kinase. Targeted drugs that block the action of tyrosine kinase include imatinib, dasatinib, nilotinib, doxutinib, and ponatinib. Thank you for listening.
Thank you very much, Dr. Samah and Dr. Amna. You both did a great job, and it was a great and informative presentation. Thank you. There is anyone has a question regarding this topic? You can go ahead.
Thank you so much, both Amna and Samah. This is great, and it's a big topic. And we see a lot of older adults with some hemoglobin abnormalities and low hemoglobin. So sometimes they have symptoms, sometimes they don't have these. But it's better to know what's going on with older adults. Sometimes they may present with some vague symptoms like just fatigue and tiredness. So think about hemoglobin. Yeah. Thank you so much. Any questions?
I still didn't finish the presentation.
Yes, go ahead.
Okay.
And we really appreciate all you do, Amna, and we understand the family. And God bless you. God bless your little ones. Go ahead.
I guess I stopped here. Anemia of chronic diseases. We have normal or increased serum ferritin and decreased serum iron, decreased transferrin, and decreased iron saturation. The bone marrow usually we find normal erythroid precursors and normal levels of iron storage. We can also do ESR or CRP. We have increased ESR and CRP. The hepcidin levels have been reported to be increased nearly 100-fold in association of with chronic anemia with chronic inflammation. Usually, the hepcidin protein is a protein that decreases the availability of iron, decreases the iron absorption. So, in anemia of chronic disease, we have increased level of hepcidin levels. Treatment is usually first directed towards the underlying cause, and there is evidence that patients with profound fatigue may benefit from iron infusions, and some patients respond to erythropoietin replacement therapy. Bone marrow failure. Common causes of bone marrow failure are due to medications, for example, chemotherapy, due to immune damage to stem cells, due to infections, some viral infections, due to marrow replacement by malignant cells or fibrous tissue. It's generally associated with suppression of all three cell lines and with peripheral cytopenia. Marrow replacement by malignant cells or fibrous tissue is typically associated with a myelocytic blood picture, which is teardropped RBCs and nucleated RBCs. We have also giant platelets, big platelets, and metamyelocytes. So peripheral blood picture can give us a clue of bone marrow failure. Sideroblastic anemia is characterized by presence of iron deposit in the mitochondria of normoblasts. The underlying pathology is defect involving iron incorporation in the heme molecules. This defect can be secondary to intrinsic marrow lesion or can be triggered by inflammation, neoplasia, nutritional deficiencies. Copper deficiency is a common example, or medications like antitubercular drugs. A typical finding in peripheral blood picture is dimorphic picture, which means we have both hypochromic and normochromic RBCs. The diagnosis is made by demonstration of ring sideroblast and by presence of myeloid and erythroid maturation abnormalities in the bone marrow. Anemia in all others is thought to lead to decreased cardiac output, local tissue hypoxia, aggravation of the comorbidities, and functional decline. It also associated with impaired performance-based mobility functions. Usually, women who age more than 65 years with hemoglobin level less than 11 have a higher risk of all-cause mortality than those with hemoglobin level more than 12. The increased risk is independent of the presence of comorbidities. I'm going to talk about platelet-related and coagulation disorders. In platelet-related abnormality, we usually have mucocutaneous bleeding, and in coagulation disorder, we usually have bleeding into tissues, deep tissues, and joint. Thrombocytopenia. When we have a low platelet count, it's considered life-threatening microangiopathic hemolytic anemia, such as DIC, thrombotic thrombocytopenic purpura, hemolytic uremic syndrome, and heparin-induced thrombocytopenia. These are differentials of thrombocytopenia. And when we have also a picture of microangiopathic hemolytic anemia, like schistocytes in blood film, disseminated intravascular coagulations, it's usually due to severe infections. Most common cause is sepsis, or due to major damage in organs, such as liver cirrhosis, or due to immune reactions, just when we have blood transfusion. It can also be due to pregnancy-related problems or disseminated cancer. We have two stages in DIC. First is there is overactive clotting, there is thrombosis, and then it's followed by consumptions which lead to bleeding. Present with intravascular hemolysis and consumptive coagulopathy. We have low platelet, we have high prothrombin time, and in ABTT, we have high D-dimer. Usually there is bleeding from many sites in the body, like bleeding from granulocytes. We have blood clots. This is the first stage. We have bruising, we have hypotension, we have shortness of breath. We have CNS symptoms like confusions, memory loss, or change in behavior. Also, we can have fever. Treatment, there is no specific treatment. The goal is to determine and treat the underlying cause. Supportive treatment that may help is plasma transfusion, platelet transfusion, and protein factor replacement. Heparin to prevent blood clotting if a large amount of clotting is occurring. The complication of DIC, if not treated early, can lead to acute respiratory distress syndrome. It can lead to heart attack, shock, stroke, venous thromboembolism, and GIT bleeding. Thrombotic thrombocytopenic purpura and hemolytic uremic syndrome. These two are very similar to each other. It's characterized by microangiopathic hemolysis, and thrombocytopenia is often difficult to distinguish. In thrombotic thrombocytopenic purpura, we have neurological symptoms and we have renal dysfunctions, in addition to fever. In hemolytic uremic syndrome, we have renal involvement. The initial treatment is the same: supportive care, fresh frozen plasma, or cryoprecipitate to replace platelet and protein factors. But thrombotic thrombocytopenic purpura respond to plasma exchange, whereas hemolytic uremic syndrome is relatively unresponsive. The causes of thrombotic thrombocytopenic purpura is usually idiopathic in about 40% of patients. The remaining case can be due to autoimmune cases, due to infections or cancers, medications, pregnancy, hematopoietic stem cells transplant. The hemolytic uremic syndrome may be preceded by episode of diarrhea, commonly associated with Shiga toxin producing E. coli or pneumococcal infection. Here we have hemolytic uremic syndrome. There is thrombocytopenia. There is microangiopathic hemolytic anemia, renal involvement. In thrombotic thrombocytopenic purpura, we have thrombocytopenia, microangiopathic hemolytic anemia. We have mild renal involvement, unlike in hemolytic uremic syndrome. We have, in addition, fever and CNS symptoms. Hemolytic uremic syndrome occurs in children, and it's caused by Shiga toxins, or it can be caused by complement disorders. The thrombotic thrombocytopenic purpura is commonly in adults and associated with ADAMTS 13 abnormalities. The treatment of thrombotic thrombocytopenic purpura is by plasma exchange. The treatment of hemolytic uremic syndrome is supportive care all. In rare case, we have complement-associated abnormalities. We can give the patient Simah. ITP, idiopathic thrombocytopenic purpura, is usually diagnosed of exclusion. We diagnose it after we exclude the most common causes. It's caused by antibody production against platelet. Patient present with purpura, with gum, with internal bleeding, all kind of bleeding. It's caused usually by medications, infection, pregnancy, rheumatoid arthritis, lupus, lymphoma, and leukemia. It also can be due to unknown cause. We do CBC, we do antiplatelet antibody test. And if it's negative, we can go for bone marrow aspiration. Symptomatic patients are treated with IV immunoglobulin and steroids. If the treatment is unsuccessful, we can go for splenectomy, chemotherapy, and thrombopoietin receptor agonist. Heparin-induced thrombocytopenia. It's caused by antibodies that bind to complexes of heparin and platelet factor 4. It's called antiplatelet factor 4. And subsequently to Fc receptors on platelet. This triggers platelet activations, intense thrombin generation, and hypercoagulable state. At the end, it will lead to life-threatening thrombosis. There is thrombocytopenia, and there is thrombosis. Can be venous clots, can be due to can cause skin necrosis, and usually is characterized by occurring in a specific period of heparin therapy. The patient is being treated with heparin. We suspect heparin-induced thrombocytopenia when symptoms occur during the period from 5th day to 14th day after initial heparin therapy. The gold standard diagnosis for it is serotonin release assay. This is usually a medical emergency, and patient required first to discontinue the heparin and then treatment with direct thrombin inhibitor. The previous one I talked about is quantitative platelet disorders. We can have qualitative platelet disorders when there is normal platelet count but impaired function. This usually happen, can be platelet function disorders, also uncommon, can cause bleeding in older adults, classified as can be hereditary disorders, just as Bernard-Solier syndrome or Glassman thrombocythemia, or can be acquired, like the most common acquired disorders are secondary to aspirin or non-aspirin NSAID. Platelet function testing can help determine the underlying etiology. Clotting disorders. Common acquired prosthrombotic conditions is, for example, like antiphospholipid syndrome, like cancer, trauma, or surgery. The inheriting protein disorders, for example, is prothrombin gene mutations. When there is mutation in prothrombin gene, we have increased prothrombin level. This leads to increased hypertrophic state. The protein C and protein S deficiency. Usually the function of them is inactivation of factor 5 and 8. When we have deficiency of protein C and S, we have increased activity of protein 5 and protein factor 5 and 8. Factor 5 leading is a mutation in factor 5 genes, make it resistant to inactivation. Antithrombin deficiency is an acquired and inheriting protein disorder caused by defect in inhibiting thrombin and activated factors 10 and 9. In older patients with unprovoked and unexplained recurrent thromboembolic event, it's reasonable to perform lab testing for inherited clotting disorders like prothrombin gene and protein C and S, or factor 5 and antithrombin deficiency. Bleeding disorders. In older adults, bleeding disorders are commonly acquired. Usually occur with patients with liver disease or clotting factor deficiencies. In liver disease, we have decreased synthesis of clotting factors, we have decreased clearance of activating factors, we have quantitative and qualitative platelet defects. Von Willebrand disease is one of the most common bleeding disorders. Older adults may also acquire circulating clotting factor inhibitors and even present with hemophilia. Similar to hemophilia in children, inhibition of factor 8 is the most common cause. The onset of hemophilia in elderly is usually sudden, and patients present with significant bleeding in soft tissues, including muscles. It's not like the bleeding in hemophilia, in congenital hemophilia, when we have bleeding in incisor joints. It's here in muscles. And treatment usually involves the factor replacement. Deficiency of vitamin K-dependent clotting factors can happen in liver diseases, can happen in malabsorption syndrome, or when using antibiotics that disrupt the normal flora in the GIT tract, which is a major source of vitamin K. Lymphoproliferative disorders also can lead to ITP, to acquired hemophilia, acquired von Willebrand syndrome, and acquired factor 10, 5, 11, and 12 and prothrombin deficiency. Renal failure also can lead to uremia, which lead to functional platelet disorder. I have like 3 questions. The first one is a 72 years old man comes to the office because of fatigue that has worsened over the past years. He has had no chest pain, shortness of breath, change in weight, or edema. He has history of diabetes, hypertension, and hyperlipidemia. He took metformin, lisinopril, and torvastatin. On examination, the blood pressure is quite bit normal. The heart rate is 72, respiratory rate 14, BMI is 28. He has pale conjunctiva, and all other findings are normal. Laboratory finding has decreased hemoglobin level, has hematocrit of 28, has high MCV, which is 100, reticulocyte count 27,000, demethyl malic acid increased, serum homocysteine increased, normal white blood cell, platelet, creatinine, potassium, liver function, and thyrotropin finding, normal folate and B12 levels. In the peripheral smear, we have hypersegmentic neutrophil. Which one of the following is most likely the cause of this patient anemia? Vitamin B12 deficiency, myelodysplastic syndrome, hyperhomocystinemia, or folate deficiency. So this is the labs. Okay, all of you said B.
Yeah. They all said B.
The answer is A. I think here we have macrocytic anemia and normal erythrocyte count and increased MMA plus hypersegmented neutrophil. This goes with B12 deficiency.
But I think Dr. Amna, they said there is a normal vitamin B12. That means it could be, the level could be normal and there's still low.
Previous figures, I think we can have B12 deficiency when we have normal levels of B12 and folate. We go for MMA and homocysteine.
Yeah, nice information. Thank you.
A 22-year-old woman comes to the office for routine evaluations. She feels well. She has rheumatoid arthritis diagnosed 20 years ago. She took methotrexate. She feels that her arthritis is well controlled. On examination, she has normal vital signs. BMI is 21. There is no active synovitis. In hard labs, there is a white blood cell count of 7.8, platelet count 3,045, hemoglobin is 10.5, hematocrit 32%, FTP is 82, ferritin 350, ion concentration 25, total ion binding capacity 220, ESR is 40. She has normal creatinine, glucose, cytotropinin level, and liver function. Which of the following is the most likely cause? Anemia of chronic inflammation, iron deficiency anemia, methotrexate toxicity, or myelodysplastic syndrome. So if you said A, correct. Thank you.
Thank you very much, Dr. Amna. It was really an informative and very interesting presentation. Does anyone have a question regarding the first topic? I can see Dr. Tlal raise his hand. So go ahead, Dr. Tlal.
Hello, everyone. I have two comments. The first comment about the first question. I think this patient, he has B12 deficiency also because, you know, he is in metformin, and sometime you'll find the patient, if he has in dose of metformin for a long time, can develop B12 deficiency. As general, the presentation is good and informative and cover a lot of area in hematology, but I think we didn't cover multiple myeloma well, because, you know, this is it is very common and it's very difficult to treat. and also myelodysplastic syndrome. These two diseases, it is really the elderly patient, they are suffering, and both of them, they can treat it by the transplant. In multiple myeloma, the patient can, the elderly patient can tolerate the auto transplant, but the problem in the myelodysplastic syndrome, the patient usually needs for allotransplant, and all the majority in the time, the patient, they are not eligible for that, because the elderly patient, they cannot tolerate the allotransplant. And thank you.
Thank you very much, Dr. Khalid. Thank you for sharing this information and for suggesting those topics to be discussed. Be discussed later. What are your opinion, Dr. Nadir?
Sorry, I stepped out for a second.
No, I see.
So what it's about the last question. I mean
yeah.
So if you can repeat your question, Talal, please and thank you.
It actually is not a question, but I give my opinion about the presentation. I said it's a good and informative presentation. Cover all the hematology problems in all age, but especially for our age group, the elderly patient, they are suffering from the two conditions is not covered here. The multiple myeloma and myelodysplastic syndrome. This is a two problem. It is very common with the elderly patient, and in the same time, it's very difficult to treat. For example, the multiple myeloma needs a lot of chemotherapy and a lot of, and sometimes needs for auto transplant, stem cell transplant, and myelodysplastic syndrome. The curative management for them, allotransplant, and usually the patient present late in elderly patient, and both of them, they are die from the infection and the complication of blood transfusion. This is my point. These two topics, I think, I think needs more concentration, because we are covering geriatrics.
Oh, sure, yeah. So I like your pointing out the most common topics or conditions. Yeah, so basically what we do, we try to use what we have as available slides from AGS. And these are just teaching slides. It's hard to cover all the important topics in one session. So most of the time they may go over the basics and then go over what we see, what you can do as a fellow when you see your patients in older like clinic or nursing homes. So I agree with you. We can discuss this in another session about these two topics in the future. Thank you so much. Any other questions? Mm-hmm.
Thank you.
I don't see any raised hand. So we can go to the next topic, which is anti-amyloid Alzheimer's drugs, and it will be presented by Dr. Ammy.
Hello, everyone. Hello, Dr. Nadir.
Hello.
Can you see my screen?
Yes.
Okay. So my topic is anti-amyloid Alzheimer drug. Is it okay if I keep my video off?
Yes.
Okay, thank you. So first we'll go over what is Alzheimer's disease. Okay. So Alzheimer's disease is a neurodegenerative disorder of certain cause and pathogenesis that primarily affects the older adults and is the most common cause of dementia. The most essential and often earliest clinical manifestation of Alzheimer's disease is selective memory impairment, although there are some exceptions. While treatments are available that can ameliorate some symptoms of the illness, but there is no cure available, and the disease is inevitably progressive in all the patients. So what causes the Alzheimer's disease? I'll just move it. Okay. So the real cause is very unclear. So there is two pathological hallmarks of Alzheimer's disease that exist in terms of senile plaques, which consist of the amyloid fibrils composed of amyloid beta peptide and neurofibrillary tangles, which consist of hyperphosphorylated tau protein. Another essential finding in the brain is in brain atrophy, particularly in the hippocampus. All the mutant genes of hereditary, autosomal, and dominant familiarity, including the amyloid precursor protein, preselin-1 and preselin-2, encode for the major proteins that involve in the amyloid metabolism. That is why patients who has trisomy 21 have APP gene locations with more amyloid accumulation and high risk of AD in the late life because they have one more copy of the APP gene, which will result in more increased amyloid production. So treatment, so the FDA has divided the treatment in two parts. So one is the drugs that will treat the symptoms. So, and when we talk about symptoms, so the memory, the thinking, these are the cognitive symptoms. So these medications are prescribed to treat the symptoms related to memory and thinking, while these drugs cannot stop the damage of the Alzheimer's disease because there is a brain cell damage. They may help lessen or stabilize the symptom for a limited time by affecting the certain chemicals involved in carrying the messages between the brain and nerve cell. For example, donepezil, which is used in mild to severe dementia due to Alzheimer. But the side effects are nausea, vomiting, loss of appetite, muscle cramp, and increased bowel movements. Galantamine or Razadine is also used in mild to moderate dementia due to Alzheimer. But the side effects are nausea, vomiting, loss of appetite, and increased frequency of bowel movements. Rivastigmine or Exelon is also used in mild to moderate dementia due to Alzheimer's or Parkinson's, and the side effects are pretty same. Memantine is also used in moderate to severe dementia, but here we can see headache, constipation, confusion, and dizziness. We use memantine, donepezil together, like Namzaric, when there is a moderate to severe dementia. These are the treatment for the symptoms. So FDA has also approved some drugs which can change the progression of the disease. So this is the anti-amyloid antibody drug. So meta-analysis of phase 3 trial data has showed moderate support of anti-amyloid beta monoclonal antibodies as a treatment of Alzheimer's disease. Monoclonal antibodies against A-beta induce clinical improvements of small effect size, biomarker improvements of large effect size, and increase in risk of amyloid-related imaging abnormalities by large effect size. So the name of the drug is aducanumab. This is a recombinant monoclonal antibody which is directed against the beta amyloid. So the beta amyloid is a microscopic protein fragment that accumulates in the brain and forms into plaques. And these plaques disrupts the communication between the nerve cells in the brain and may also activate the immune system cells that trigger the inflammation, endeavor disabled nerve cells. So FDA has approved aducanumab for the treatment of mild Alzheimer's disease using the accelerated approval pathway based on the positive clinical results on one of the two pivotal phase 2 clinical trials. And aducanumab's effect on the surrogate endpoint of reducing the amyloid beta plaques in the brain. Excuse me. So here we can see how the anti-amyloid antibodies can improve the disease condition. So as a class, the monoclonal antibodies can improve the cognitive outcomes on ADAS-Cog. ADAS means the Alzheimer's Disease Assessment Scale, and also in MMSE by small effect. But it did not improve the cognitive functional measure by the Clinical Dementia Rating Scale. Decreased amyloid, it was seen that there was a decreased amyloid in the PET scan. This reduction was correlated with the effects on improved ADAS. There was also a decreased amount of tau protein in the CSF by large effect size, and increased risk of ARIA means amyloid-related imaging abnormalities by a large effect size. On the contrary, in the subgroup analysis, we see through the individual drugs. For example, the aducanumab improved the ADAS score, the CDR, and a measure of activities of daily living by small effect size. It also decreased the amyloid in the PET scan, and in the CSF protein, it has also decreased the tau protein by large effect size. On the contrary, solanezumab improved the ADAS and MMSE by small effect size, and improved the CSF by moderate effect size. Bapineuzumab, gantenerumab, and crenezumab did not improve any clinical outcomes. All drugs were increased ARIA risks except of solanezumab. No ARIA risk was reported in patients' studies with crenezumab. So who will get the aducanumab? So there are certain criteria we need to follow before we select the patients who will get the medication. For example, we will take the patient who has mild cognitive impairment or mild dementia. So cognitive decline should be mild, and testing cutoff such as MMSE score should be more than 21. Then a Montreal Cognitive Assessment Score should be more than 17, and CDR, which is Clinical Dementia Rating, should be 0.5 to 1. Formal neuropsychological testing can be considered for quantification of deficits and changes over time. Also, we need to have the documentation of amyloid pathology. Clinicians should limit use of aducanumab to those who has proven to be amyloid positive by amyloid PET scan or lumbar puncture, which was also required in clinical trials that has evaluated the drug. And also, the most importantly, there should not be any kind of contraindication. Like patients with cognitive decline attributed to non-AD pathologies like Lewy body disease, vascular disease should not be offered aducanumab. At present, experts suggest against treating patients with AD in the setting of Down syndrome as well, until there is more information available. So what will the dose be like? So aducanumab is usually administered by intravenously infusion every 4 weeks. Typically, it is done in an infusion center. A recent, which is within 1 year, brain MRI is required prior to initiating the treatment. Additional MRIs are required during the dose escalation. So dose 1 and 2, which is given on week 0 and 4, is 1 milligram per kg IV over 1 hour. Dose 3 and 4, which is given on week 8 and 16, is 3 mg per kg IV over 1 hour. A brain MRI is required prior to initiating a 5th dose. Dose 5 and 6, which is given on week 24 and 32, is 6 mg kg IV over 1 hour. Then again, we have to do an MRI before initiating the 7th dose. So the dose 7 and beyond is 10 mg per kg over 1 hour. So what can be the adverse reactions? So there are two major kinds of adverse reaction that we can expect. One is amyloid-related imaging abnormalities, edema, which is ARIA-E, consistent with vasogenic edema, or sulcal effusions. And another one is amyloid-related imaging abnormalities, hemosiderin deposition, which is ARIA-H. It is characterized by superficial siderosis and microhemorrhage, commonly occur with aducanumab therapy. Patients may develop ARIA-H with concomitant ARIA-E. In patients who developed ARIA-E during clinical trials, most cases were mild to moderate in severity. Recurrent episodes have also been described and were less symptomatic than initial episodes. Clinical symptoms suggesting ARIA-E or H may include altered mental status, confusion, delirium, disorientation, dizziness, headache, nausea, seizure, vertigo, and visual disturbance. Usually, we expect the resolution of ARIA within 12 to 20 weeks in majority of the cases. And that is what we have seen in the clinical trials. So what are the risk factors and who can get this ARIA, like the adverse effects more? So patient with, for the risk factors with ARIA-E are patients who are apolipoprotein E, E4 carriers. So dose risk increases with higher doses and during dose titration. And patients who gets the ARIA-H, which is the microhemorrhage, are the patients who also have the apolipoprotein E carrier, also increasing age, greater number of microhemorrhage at the baseline, and older people with cardiovascular risk factors or evidence of prior cerebrovascular events. So it is important that we check the apolipoprotein E before we start the medication. There are also some minor adverse effects, like in 1 to 10% case, there can be a diarrhea, altered mental status, confusion, delirium, disorientation. In less than 1%, there can be an urticaria, angioedema, antibody development, and seizure. So how should we monitor? We have to clinically assess the patient throughout their medication. So during the titration phase, patients should be monitored for clinical symptoms suggestive of treatment-related adverse effects, like headache, confusion, any kind of focal neurological sign, including the vision disturbance. Serial monitoring with cognitive tests should be administered by the clinical team with each dose administration. In addition, because the presenting symptoms of ARIA may be subtle, and because patients may not be able to report their own symptoms, we recommend that patients are monitored for clinical change by a designated family member or a friend for the duration of the aducanumab therapy. If this is not possible, remote cognitive assessment tests are administered by the treatment team, could alternatively be used to monitor the cognitive status. And MRI is the best way to monitor the patient. A brain MRI is required prior to initiating the therapy, as well as prior to the 5th, 7th, and 12th dose to assess the possible adverse effects, especially the ARIA. In addition, a brain MRI should be performed for any symptoms suggestive of ARIA. If the brain MRI shows ARIA, the patient should be evaluated clinically. Asymptomatic patients with mild MRI findings, patients who are asymptomatic and who have mild MRI findings may be able to continue aducanumab with close clinical monitoring and monthly MRI scans. However, the aducanumab dose should not be increased until the ARIA-E resolves, even if the patient is asymptomatic. And in symptomatic case, patients with moderate to severe MRI findings, aducanumab should be held for moderate or severe ARIA or severe symptomatic ARIA of any severity. Monthly follow-up MRI scans are required to determine whether aducanumab can be restarted in the future after the resolution of ARIA and documented for stability of any hemorrhages. Okay. Thank you. So this is what I prepared so far.
Thank you very much, Dr. Amy, for the informative presentation. Thank you. Does anyone have a question or comment? Sorry, Dr. Nadir, go ahead.
Yeah, thank you so much. Thank you, Amy. This is really informative as well and concise to the point. And I know you are sick, but hopefully you feel better. So this new medicine is used selectively, as Amy mentioned. So you have to go through the criteria for certain patients, and those who meet the criteria, then you can start the medication, and it's usually in a center where you will have the IV and the like infusion. It's very expensive, so everyone will get it. Thank you. Any questions?
Any question or comment, please? I don't see. Okay.
We can go to the next agenda. No question.
Yeah, we can go to the next presentation, which is about histogram and other graphs in Google Sheet and Excel. And it will be presented by Dr. Isra, Hamza, Dr. Mohammed Usman, and Dr. Shaza Hassan.
Assalamu alaikum, everyone. My name is Isra Hamza, and today I'm going to present to you histograms and other graphs in Google Sheets and Excel. Okay, I'm looking for it, okay. Do you have my screen now?
Not yet.
No. Not yet? Okay.
Yeah.
Do you see it now?
No.
No. I don't know what's the problem. Okay. Yes, okay. Okay, we try to do it again. Okay, share screen.
Yeah.
Okay, great. Slideshow. I don't know why it's not playing. Okay. Here it is. Sorry for that. Histograms and other graphs in Google Sheets and Excel by Isra Hamza. First, we need to know what is graphs. Okay. It's very slow, I'm sorry. Graphs are graphic representation of data, and it's also known as visual summarization of data. So instead, for looking to set of data, we're going to look for a picture that explains everything for the reader to be easier to understand how this data have been distributed. Before going to explain histograms and do it together, I'm going to do just a reminder for some statistical terms, definitions. Variables are defined as numerical data. So charts are dealing with measured data, and this data, like sales, for example, or number of dollars or test scores. We have also the minimum value, which is defined as the lowest data in the data set, and also the maximum value, and the count of values, which refers as n. And I mean by that, how many number of data we have in this data set. The difference between the minimum and maximum value is defined as the class interval. So if I want to distribute the frequency of data, I need to do grouping of data. And by that, I mean the class interval. Also, it's known as the width of data or the width of values. The difference between maximum to minimum, for example, if we have range of data from 0 to 100. If I want to do some grouping, I will just divide this into groups. For example, from 10 to 30, 30 to 50, and so on up to 100. So this is the class interval, okay? Every one of them. And the width of this graph, I calculated by subtracting the minimum value from the maximum value. So in this case, from 30 minus 100 equal 20. So the width of each class interval is equal to 20. Number of class intervals means that the size of each class into which the range of variables are divided. And this is represented by divisions or column of histogram. And I will show it later on. Histogram is defined as a bar graph, like representation of data, that buckets a range of classes into columns along the horizontal x-axis. So we have the x-axis and the y, and each column represents different class interval. The vertical axis represents the frequency or the number count or percent of occurrence in the data for each column. Column can be used to visualize the pattern of data distribution, and this is mainly the goal of this graph. We have the polygon also. We have the histogram and polygons, which shows the number of or the shape of data, and also we have the ogive, which shows the cumulative frequencies. I have this picture just to give you an idea about the histogram. This is the histogram, sorry. The histogram on the left side of the screen, and this is the classes. We have here 1, 2, 3, 4, 5 classes of intervals, okay? And here we have these classes, you see, 1, 2, 3, 4. So it's okay if it's 4 or 5, no problem. And here we have the frequencies, sorry. Okay, if you see this histogram by just looking, I can see that the majority of data falls in the first group, and the least one falls in the last group, which is between 94 to 94, not 95. Okay, this is just an example, random example. I will explain everything later on. Okay, so we need to go to Google Sheet. Sorry for the noise. I need to go to Google Sheets right now to do the histogram together. Hopefully, by the end of this session, we are going to know how to do histogram. Sorry. Okay. Any question at this point? Any question at this point?
No, thank you.
Okay, great. So this is our Google Sheets here. And I just created a random data. And this is the X value. Just a second. Just a second. I'm sorry, everyone. Okay, so I created just a set of data, random set of data. And as you see here, it's around 16. And together we are going to see how we calculate the minimum value and the maximum value and the number or count of data, and also the class interval. The good thing that Google Sheet does everything for us, but today we are going to learn how to do this. Okay, so here we have the minimum value. Okay, you press equal, open bracket, and then type minimum here. And then we highlight our whole data and press enter. So the minimum value is 15. And the maximum value equal, open bracket, max. Highlight the data. And here the maximum value is 98. The count number of all these variables here, you press equal, open bracket, count, and here we go. Highlight our data. Sorry, something went wrong. I will do it again. Okay, equal, count, tab here, then highlight. And as you see here, from A2 to B16, and then press. And number of variables are 15. Okay. As you see here, the Google Sheet suggests that the class interval would be 14, but we can calculate it together. All right. So to know the class interval, we need first to know the width of this class interval or the range of data. Okay. And I can do this by doing the square root of total number, which is 15. Okay, and to this we're going to do equal, open bracket, square root QRT of 15. And it's around 4, 3.87. I will go and round it up to 4. So the number of classes would be 4. So we have 4 groups, okay? To know the width of this group, the width, I mean like the difference, the range of data, okay? So I'm going to equal, open bracket again. I'm going to subtract the minimum value from maximum value. Here we have 98 minus minimum value, which is 15, close the bracket, divided by 4, which is number of classes. And press enter, and we have 20. And what I mean by that, if our data range from 15, let's say a minimum value is 10, for example, we're gonna go down a little bit to make sure our all data involved in this range. So our data would be from 10 to less than 10 plus 20 equal to 30, right? So the range is 20, 10 to 30, okay? So that's what I mean by the width of data. So it would be 10 to 30, 30 to less than 50, 50 to less than 70, and so on up to 100, okay? In this case, our group or class intervals are included in our range from 10 to 100, or from 15 to 98. I just go a little bit more than our limit to make sure that is our maximum value is involved in our range, okay? This is just explanation, but the Google Sheet does everything for us. So let's do it. Let's do the histogram. Let's do the histogram. All right, so this is our variable X. I'm going to highlight it. I'm sorry. No. All right. Here, and you see here the insert. First insert and go down to chart. And here it is. This is our chart. But we don't want this. We want to do histogram, and we can change that, okay? Here, the chart type, and we choose histogram. Okay, this is our histogram. No, this is not histogram, sorry. This is column. Okay. I don't see histogram. Why not? Dr. Nadir, could you help me? Here it is. Yeah, I found it. Okay. So this is our histogram here. You see, this is our X value, and the range chosen by computer is from 10 to 28, which is around 18, right? And we said 20, so it's fine, no problem. So as you see here, from just by looking, I could know that the range, the highest range of data is 4 between 28 to 40. Okay. So the height of the column represents the numbers or frequencies of data falls into this range. Like you see, we have 1, 2, 3, 4 classes, and we said before that we could end up by 4 classes, right? So this is what histogram does, and this is we could do some customization. We could change a little bit. So let's see here, for example, we could customize. And we could press here the histogram. Okay, this is bucket size, and what we mean by bucket size means the range of data. And we said that we want the width of data to be 20, right? So we could change that from 18 to 20. Okay, we just press 20, and see what's will going on. That's it, everyone. Here we have our data from 10 to 30. 30 to 50, 50 to 70, 70 to 80, and 90. Because I don't have, I just selected this data randomly, so I don't have 80 something, which is fine, no problem. But if I have 85, for example, we would end up by another column here, and it could be like 5 columns instead of 4. All right. So the important thing to note is that our all data has been involved in this chart. From 10 to 100, minimum value is 15, and the maximum is 98, all right? So this is our histogram. Let's make some change again. We could change this chart and add this title, for example. Let's say this histogram of test score. You see here, this is our title. This is the histogram of test score. And we could also make a change again. We could change the horizontal axis title. Okay, so let's press. These data are the test score. All right, and you see here test scores. And let's change the vertical axis. Let's say, for example, this vertical axis represent the frequencies of this data, the frequency of this test score. And let's say this is number of a student. All right. Here it is. We got the number of students, and we have the test score. And this is histogram, everyone. From the start, we could just select our data, highlight our data, and just press insert and do the histogram. Any questions so far? Any questions so far? Okay. I have another thing to say. This is where you edit your histogram here, this right panel. Okay, edit chart, and here you have this paper that this is screen. Okay, and also you could just press here and look to every column. You could see the count and the range. You hear the first column, range 10 to 20. We got five, sorry. You got 4 values here, 6, and you got the range and the count at the same time. So that Y graph is just a visual summarization of data. Just by looking at this graph, I could know everything. Any questions so far? Any question? That is everyone. I hope you have an idea how to do histogram.
Yes, thank you.
You're welcome. Any question? Hello?
Hi, Isra. No question.
No question? Okay, just I have another thing to say, that just to Dr. Muhammad will talk about the polygon graph and Dr. Hiza will talk about the ogives, but I just want to show you that the polygon represents the midpoint, which is here in the mid. If we point this from 10 to 30, like for example, the midpoint would be here, which is 30 plus 20 divided by 2, which is 20, right? So it's here and here. If we just make connect the point from here up to this midpoint, and this midpoint, we have this shape, and this represents the polygon, just like this. So if we don't have any question, I'm done right now. Thank you, guys.
Thank you, Professor.
I should stop sharing just a second. Okay, stop here. Yeah, found it.
Dr. Hashmi, you can see your screen. So you can start. Dr. Hashmi, we can't hear your voice. I think maybe he has a problem with his microphone.
We can skip to the next part.
So this Shaza, can I start instead of we can do it after?
Yes, please. Thank you.
Okay. Do you see my screen?
Yes.
Yes, you can see it.
So I will talk about ogives today. So definition. In statistics, an ogive, also known as cumulative frequency graph. It's also known as cumulative frequency polygon. Ogives are graphs that are used to estimate how many numbers lie below or above particular variable or value in data. Definition continue. To construct an ogive, firstly, you have to calculate cumulative frequency of the variable using the frequency table. It is done by adding the frequencies of all previous variables in a given data set. It results on, or the last number of the cumulative frequency table is always equal to the total frequencies of the variable. So you can see it here in this figure. In this figure, we have like a class of student and their score in the test. So score from between 50 and 60, 60 to 70, 70 to 80, 80 to 90, and 90 to 100. The frequency is, for those is 5 who got 50 to 60, the other who got 60 to 87. When we try to calculate cumulative frequency, we'll do it. I will show you in the Google Sheet at the end. So we add it together. So the people get 50 to 60 is 5 people, and the people who get less than 70 will be added together. 7 to 5, it will be 12. Most of statisticians use ogive curve to illustrate the data in the by pictorial representation. It helps in estimating the numbers of observation which are less than or equal to the particular value. Ogive graph represent horizontal axis, usually called x-axis, and in our class score, it will be class score, and the vertical axis, it's called y-axis, and it will represent cumulative frequency. Ogives are useful for determining the median, percentile, and 5-number summary of data. Remember that the median is simply the value in the middle when we order the data. With an ogive, we will already know how many data value above or below certain point. So it is easy to find the middle of the data. We have two types of ogive. It is less than and greater than. So less than ogive, the frequency of all preceding classes are added to the frequency of the classes. And the more than, the frequency of the succeeding classes are added to the frequency of the classes. And the shape will be like this. So in this graph above, it represents the rows curve represent the rating curve, the rose color represents less than ogive. So this one, the pink one or rose one, and the purple one represents the greater than ogive. Okay, so here they explain how to draw less than and greater than ogive, and we can see that on the Google Sheet. Okay, so let me go to Google Sheet. So I have to stop sharing this.
Mm-hmm.
So I have just so here I want to calculate cumulative frequency. So cumulative frequency, we mentioned it is added the frequency for the student who get 50 to 60, the number of students, the frequency of them is 5. And for a student who get 60, less than 70, it includes all this 2,000. So it will equal B2 plus P3. So it will be this. And we can drag all together to give us the whole value. So the student who get more than more than 70, between 70 to 80, it will be all those together, 12 plus 7 plus 5. 4, and the student get more or less than 90 will be all them together. So we can drag it together as we mentioned before. So it will be 34, and the student get less than 100 will be all together added together. So 6 plus 12 plus 10 plus 7 plus 5, it will be 40. So from here, we want to do our charts. So we highlight this. The ogive chart is a cumulative frequency chart. So, and we also highlight cumulative frequency and then insert chart. And this will be the chart. So, but I want the chart to be like a curve chart or line chart. So it will be like this chart. And as Isra mentioned before, I can change the title of the chart. So it will be cumulative frequency chart, or I can just put it as ogive chart. Okay, that's all about the ogive chart. And you can as Isra mentioned before, you can edit if you want to change the x-axis, the name of it. So it's here, the class score, and the vertical axis, cumulative frequency. If you want to change anything, change the numbers here in the x-axis. You can as she mentioned before, you can change it from here, edit chart. Okay. So, any question in this ogive chart, cumulative frequency chart? So we'll do it like that. We can go to do like more than or less. We said that ogive chart is 2 types, more than or less than ogive chart. So we can, if we want to do more than, so here is a class score. So here it started from 50. Anyone has beginning and end point, 50 to 60, 60 to 70. So the small one in the left side, we'll put it as more than. So when we check, we said that the student get more than 50, more than 60, more than 70, more than 80, more than 90. Or we can put it as student who get less than 60, less than 70, less than 80, 90, 20 here. So we have it like this, more than the small numbers, less than, we took the bigger end number, okay? And then we calculate the cumulative frequency as we did it before, okay? For less than, people who get less than 60 here, the student who get less than 60 is 5 students here, okay? The students who get less than 70, we calculate it, as we mentioned, equal B2 plus E3, and then we enter. So, and it go all together like this for less than, and for more than, the same way, more than cumulative frequency for more than. So the student who get more than 50, it will be the more than 50, it will be all this, all of them. We make a summation of all of them who get more than 50. So it will be the total of the student, the total of the cumulative is 40, who get more than 60, more than 50, and it will go it will go like, so who get more than 50 will be all these students. The total is 40. Who get more than 60 will be all those, no, all those together. So we add all this together because they get more than 60. So it will be all of them minus 5 and so on. So if I want to do the more than ogive, so I will highlight more than ogive and then more than cumulative frequency. Oh, sorry. So if I want to highlight it, I will highlight it there this way and then click Control to highlight the more than cumulative frequency. And then I want to put it as I want to do it in a chart, more than ogive chart. So insert chart. So, but I want it to be like, voice scanners. So I feel like it's more than and more than cumulative frequency. So yeah, comes like this. Something went wrong. And the same way we can do it for less than and less than cumulative. Oh, sorry, I have to hold Control and this one. Okay, so any question? So do you get the idea how to do it? So calculate the cumulative frequency, and from that you get the ogive, and less than and more than ogive. Also, you calculate the cumulative frequency, and then you make the ogive chart by highlighting more than and more than cumulative frequency, and then create a chart. And for less than 2, you highlight the less than the class score, and then highlight the less than cumulative frequency, and then you create the chart. So that's all I have. Any question regarding that?
Thank you very much, Dr. Shaza. I don't see any raised hand or any question in this chat. So Dr. Hashmi can continue his topic.
Hello. I'm sorry that you faced an inconvenience. So there was a technical issue. So I think I'm able to. Can you please hear me?
Yeah.
Okay. Okay. Fine. So can you please stop sharing, Dr. Shaza? Because I'm unable to share my screen. Okay. Thank you. It says you cannot start screen share while the other participant is sharing again. Hello.
Yeah, you can share now.
Yeah. Okay. Can you please see my screen?
Yes, we can.
Okay. So my colleagues, Dr. Isra and Dr. Shaza, explained very concisely and in a very beautiful manner the descriptive statics, particularly the histogram and the Ogive graph. So I'm going to talk about frequency polygon. So first of all, we're going to cover the definition. So the definition can be a frequency polygon is a graph that uses lines that connects the points plotted for the frequencies at the midpoints. So in this case, the high yield point or the main point is midpoints of the classes. So not the range. It is basically going to connect the midpoints of the data set. So frequency are represented by the heights of the midpoint. So this was about the definition of the frequency polygon. And the next thing, how to draw a frequency polygon. So we can draw a frequency polygon on hand by hand on the paper, or we can draw a frequency polygon on an Excel sheet. So today we're going to talk about how to draw a frequency polygon on an Excel sheet or Google Sheet. So we can, there are two methodologies to draw a frequency polygon. We can draw either with the help of a histogram, or we can draw without a histogram. So this is a way to draw a frequency polygon, with a histogram. You can see that these rectangles basically represent the histogram, and this line, which is connecting the various points in the data sets, or like you can see that if we see this small rectangle, so it is showing a data set between 100 to 200, and the mid range should be 75, between 100 to 200. So sorry, 150. So this point, and then you can see there's between 200 to 300. This is the midway. So this is connecting this point, this line is connecting this point, and then this point, and then this point. So this line connecting all the midway point is known as the frequency polygon. So next is how to construct a frequency polygon. So first of all, we must be having a data set, and then we have to find the data interval, and then we are going to have the midway point. Like I told you that we are going to connect the midway point, or so midway value. So we are going to find out the midway point. So let me share my Excel sheet with you. So you can see, can you see the Excel sheet now?
Yes.
Okay, so this is just a rough and raw data I have put into the Excel sheet, and you can see that. And this is basically class interval, like 10 to 19. I have put the data into class interval. My colleague Dr. Isra talked about in detail about how to calculate the class interval. So like I have, I'm not going into detail. I'm just telling you that I have put data into class interval, like 10 to 19, and then 20 to 29, and then 30 to 39, and then 40 to 49. So this is the minimum value, and this one is the maximum value. And this one is showing the frequency. And we have to calculate or find out the midpoint. So how we are going to find out the midpoint? So it is very simple, and we can calculate the midpoint by adding these both values, 10 plus 19, and then we can divide it by 2, because we're going to take the average. So you can see that in the other sheet I have done this. So it is 14.5. So you can do this by using the Google Excel sheet. You can just put equal, and then parentheses, and then add column A and column B, right? B3, this column is column B3, and this one is column A3, and then the value would be 14.5. And then you can calculate all these values, right? So this is basically the midpoint of all these values. So the midpoint for 20 plus 29 is 24.5, and midpoint for 30 and 39 is 34.5, and midpoint for 40 and 49 is 44.5. And similarly, the midpoint for 50 and 59 is 54.5. And this frequency, I have just copied it here, right? So this is the frequency shown here. And then we can, like if we want to draw the frequency polygon, so I have basically drawn it earlier. So we can draw another graph. So all we have to do, like my colleagues, my worthy colleagues mentioned, that we have to highlight this frequency, and then we can click on this insert option, and then we can select chart, right? So, and then we can see, because I mentioned earlier, it is a line graph. So we are going to select a line graph, right? We're not going to use a bar or something. We are going to use a line graph. And this graph is basically telling you information about the data set. So you can see that this point is basically 11. So you can see that there is 11, and the midway point here, midpoint is 14.5. So at this point, frequency is 11 and midpoint is 14, and this is connecting the data set at this point, at the midpoint of this this site. And then we can see that at this point the frequency is 3, right? We can see that frequency is 3, and at this site the midpoint is 24.5. And similarly, we can see that at this site the frequency is 7, and the midpoint is we can see that 34, right? And we can increase gradually, like, in a sequential manner. So this is how it is going to convey information about the midpoint of the data set. And we can change, edit the chart. We can change the axis. We can label the label our chart, and we just can right click it, and we can change the title. We can name the axis, name the x-axis, y-axis, and So this was just a brief description what is a frequency polygon and how to construct it. Do you have any question? Hello.
Yeah, no, Dr. Hashmi, no raised
Okay.
hand, no question.
Okay, thank you so much, and I'm again sorry for the inconvenience you faced.
No,
Thank you so
worries.
much.
Yeah, thank you so much, all of you, Dr. Isra and Dr. Hashmi and Dr. Shaza, for the clear and informative presentation.
Thank you.
Yeah. Does anyone have a question or a comment? No one. This will bring us to the fourth topic in our presentation. Can we continue, Dr. Nadir?
Yes. So thank you so much for the presenters, the three last presenters and before that. So thank you so much. This is great. So for those who have any applications, you can continue with your other applications. This will be recording, so you can come back and follow the next section. So we will continue with the meeting. I know it's more than 2 hours, so we will go ahead with the last section, and then we'll plan for next meeting. So go ahead when you are ready.
Oh. Okay, thank you so much. Okay. Yeah. The last topic in our presentation will be about the presentation skills. Can you see my screen?
Yes.
Yes.
Yeah, and it will be presented by me, Maarib Hassan, and Dr. Omar Khalid. I would like to share with you different phrases and expression that you can use in different scenarios during presentation and online video discussion. And there are 7 phases of an online video discussion. The phase 1 it is to prepare for a successful discussion. This would be before the discussion begins, and you should test the software and your microphone and video, and you should also ask your participant to do the same. If you have never, especially if you have never used this video platform before, and you can do this by sending an email to the participants, or by write down the by create a slide and write down you can tell them we will open the meeting room early so that you have time to test your microphone and video before the meeting. This is in a form of email, and or you can create a slide and write down welcome to insert the meeting name. And to prepare for the best experience, please check your audio and video before we start. Use headphones during the discussion. Our discussion will start right on time. And you also should review the agenda and share it with your participants. This is the first phase during presentation and video discussion. And the phase 2 is to welcome your participants, welcome, greeting them, and give a brief introduction. You can say good morning, good afternoon, good evening, everybody, and welcome to my presentation. My presentation is, my name is, give them your name, and I am, can put your job title at where you are working. And the topic of my presentation is, give them the topic. Today I would like to talk, or I can say today I would like to talk about and give the title of your presentation. You can say that I am happy to join you today. I'm looking forward to our discussion today. I'm thrilled to be here. There are some, if you see unfamiliar people, you can ask them to introduce themselves. As you can see, you can say There are some unfamiliar faces here today, so let's do a quick round of introduction. The second step, you should give an overview, like saying, I'm going to focus on or look at or deal with 3 main points. I've divided my presentation into 3 main parts. First of all, I will talk about. Second, we will look at, and finally, I will explain or show you or tell you about. It's very important to check for your time and tell your participant about how long you will finish your presentation. Like saying, my presentation will take about number of minutes. And to ensure not taking the conversation away from the track, you can say that there will be plenty of time for questions at the end of my presentation, or I would appreciate it if you could leave any questions you may have until the end of my presentation. And during this phase, you can make your presentation more interesting by not asking what the presentation title, but ask why you choose this topic. And this could be by telling your audience a person anecdote. You can say, so why am I telling you this story? Well, the goal objective of my presentation is to persuade you, convince you to, inform you about, encourage you to, or help you, show you. This will make the presentation more interesting. And of course, the story, it should be related to the topic of your presentation. And you can say, on my last holiday, I was lying on the beach reading a book by the author name. When I started to think about, I remember when I started my first job, I was very nervous and I didn't know anybody. This will make you can take the attention and the focus of your audience by this way. Phase 3. It's about establish ground rules to ensure smooth communication and minimize distraction. You should demonstrate and encourage active listening by telling your audience, if you have any question during the meeting, the easiest way to let me know is to use the raised hand emojis, as we all do during this presentation. This weekly meeting, and you can say, don't hesitate to let others know if you agree or like something that they said by using the clapping hands or thumbs up. If you have any difficulties or need to leave early, please let us know by sending a quick message in the chat. And after establishing the ground rules, you should introduce your first point. You should go to the body of your topic by going through the points you've mentioned in the introduction. You can say, I would like to begin by showing you, let's start with, so let's get it started, and finishing with a point or topic. Okay, so that cover and sorry, can you see my screen? I think
yes.
I broke.
Yes.
Okay, thank you. Or you can say, that conclude my second topic and continue with other. Now let's move to my next topic, which is tell them, let's turn now, or moving on to these phrases you can use when you're presenting your body of the belly of your topic. And if you have a graph you would like to share with your audience, you can say that that as you can see on this chart, or take a look at this chart, this graph clearly shows, this graph highlights the importance of, and when going into detail, let's expand on this point. I would like to elaborate on this point for a few minutes. And during your presentation, you should remind your audience about the purpose of the presentation by saying, as I said at the beginning, this relates to what I was saying earlier. This ties in with what I said at the start of my talk or my presentation. And during this phase, you can make your presentation more interesting by use a rhetorical question, which is a question that without expecting answer. That may be because the answer is obvious, or you just want to get audience thinking about the question. And you can give an amazing, surprising, or shocking fact or statistic, something new connected to the purpose of your topic, and enough to capture the interest of audience. Like you can say, in the last 12 months, employees turnover has increased by 22, or any other fact that is surprising. And tell your audience to imagine something. You can tell to imagine anything. Like this is an example. Imagine you arrive at work one day and there is a buzz in the air, the office seems brighter, everyone is in a good mood, and boss gives you a friendly smile when she sees you. Those are four techniques to make your presentation more interesting. As I said, they are first, to give an anecdote, which is a short story, and use rhetorical question, give amazing, surprising fact or statistic, and tell your audience to imagine something. And we will go to the phase 4, which is practice effective time management. Prepare and share. This start by preparing and share the agenda in advance. Encourage appropriate turn taking. If you encourage discussion during the meeting, and stay on one topic or easily retain to the topic. You can use the phrases that if you receive a question from someone, or if someone interrupts you and you have strict of time, you would like to go through your agenda first, you can say that you would like to. That is a great question, but I want to make sure we have time to get through our full agenda. So let's come back to it at the end of today. Or you can say, thanks for asking that question. I'll make sure that we save time at the end of our meeting today to answer a question that are outside of the agenda. And if someone interrupts you, you can reply with, that's a great idea, or a suggestion. Hold on to that thought, because I'd like to come back to it at the end of the discussion today. Or appreciate your comment. That's a really good point. Let's see what others have to say. And if you know that just a little time left and you still have topics you need to discuss in your agenda, you can use this sentence. We are almost at the end of meeting, so let's get through the last 3 items. This will help the participants to retain to focus on your agenda. And the phase 5 is to handle interruptions. The interruption could be from participants, or from a background noise, or it may be a technical issue. So you can say, I'm so sorry. You'll have to forgive the noise in the background, which may be a construction or noise outside, or a child cry. And you can say also, could you come back to me in a moment? I have to put myself on mute. Do you say something, Dr. Nadir? Okay. Or I have to put myself on mute for a second. Okay, and and if you get interruption by a participant, you should respond with appropriate phrases. Use with technical interruptions, let participant know what is happening and what you will do going forward. The phase 6 is to ask others to wait if you need them to wait by saying, bear with me for a moment. I seem to have lost my presentation slides. Or please wait for a moment while I get ready to share my slides. I apologize for the wait. Please give me a moment so I can share my screen. And the last phase is to summarizing, concluding, and thanking your audience, and invite them to ask a question. In the summarizing, you can use, so that brings me to the end of my presentation, or we looked at 3 main points. First, I showed you or spoke about and give brief 1 or 2 sentences about the main purpose of your presentation. Then we looked at and finally explained or told you about. You can also say to quickly recap. This is while summarizing. And then to conclude, I would like to say, or before we finish, I'd like to leave you with one final thought. And as I said before, thanking and inviting to ask questions. Thank you very much for your attention, time. Thank you for listening. If you have any question, I would be happy to answer them. And you can also say that we got a lot done today. Thank you so much for your time and patience. Thank you everyone for coming. This was a fascinating discussion. Those are phrases you can use during presentation or while when there's a meeting, a discussion. And this brings me to the end of my presentation. And if you have any question, I will be happy to answer them. If there is no question, we can go to the other part of this topic, which will be presented by Dr. Omar Khalid.
Thank you so much, Dr. Maarib. This is great, as well as the previous presentation. So thank you so much.
Thank you so much. Okay.
Okay. Hello, everyone.
Hello.
Can you hear me?
Yes.
Yes.
So can you see my screen?
Yes.
Yes.
Okay. Hi, everyone. I'm Dr. Omar, and today I'm going to talk about a very important topic, and it's also simple, and I will try to make it faster. So I will talk today about connecting sentences. So we will know by the end of this presentation how we can connect different sentences. Okay, before we know how to do that, first we need to define the sentence. So what is a sentence? The sentence is a group of words consist of verb, subject, and complete idea. So for example, let's take this example. Ahmed is talking about grammar. So here we have the subject Ahmed and the verb is talking. And now we have the full idea of the sentence. We don't need any other centers to understand the idea. The other thing is the clauses or the clause. The clause is a smaller unit than the sentence. It only needs a verb and a subject. So no need for a complete idea. Also, some sentences, some clauses have a complete idea. So based on that, we can divide it into independent and dependent clauses. So the independent one it can stand alone because it have a complete idea like the sentence, and we can consider it as a sentence. Let's take this example. You can have an ice cream. So we have a subject, we have a verb. The subject is you, and the verb is can have. And we have the idea. No need for any other clause to understand. But if we see the other example alone, like after you clean your plate, we see that the word after make it dependent. We need another clause to understand what the writer want to say. If we see the last example, after you clean your plate, you can have an ice cream. See that the first part is dependent and the second part is independent, and when we connect it, we can have the full idea. This is the idea of the independent and dependent. So my topic today will show us how to connect these different type of sentences and clauses. So to connect different sentences, we have many ways. We will talk today about coordinating conjunction and subordinating conjunction and conjunctive adverbs, and we can use also the colon and the semicolons. We will talk about each one in the next minute. Okay, let's talk first about the coordinating conjunction. In this type of conjunctions, we use what we call it the fan voice, and you will know it in a second, to connect two equally independent clauses to make a compound sentence. So what is a compound sentence? The compound sentence consists of two independent clauses. We can connect it in a different way. We can use the coordinating conjunction with the fan voice. We use this formula, as you can see here. We put the first independent clause. We have to use comma between the two clauses, and then we use one of the fan voice, and then we put the second one. So it's very important to put comma in between them. So what are those fan voice? It stands for, we have the fan voice are these words. We have for, and, nor, but, or, yet, and so on. So you can easily remember it by remembering the word fan voice. In the second column, we can see the meaning of each one, and we see some examples. Let's see the first one, for example, for. Or it has the same meaning of because. And if we see the example, Sam drank some water. This is the first sentence. As we can see, it's independent. We don't need. We can use it as a sentence without any other clause. And the second part, he was thirsty. So we can use the word for, which means because, to connect these two sentences. So it will be Sam drank some water, for he was thirsty. So now it's a one sentence, and always remember to use the comma to separate between the two clauses. Okay, is it clear? Hello guys, can you hear me?
Yes.
Okay. For example, let's see another example. Let's say but, which means however. It has the same meaning of however. As the example is, all the children want to eat pizza. This is pizza. This is this is an independent clause. We can use it alone. And also the other independent clause is no one want to buy it. So it's also independent. There is subject, verb, and complete idea for each one. But we want to connect them both. We use one of the fan voices, but, and we use the comma. So now we have the full sentence. All the children want to eat pizza, but no one want to buy it. Okay, and so for the other examples. So this is the coordinating conjunction. Okay, let's see. Also, we have to remember all the time to put the comma when we connect two independent clauses, as we see in the previous examples. And also we use the comma with the fan voice if we are connecting items in a series. So we have many items, more than two, and it come in a series. And so we have to put the comma between the items. For example, I have this example. I recommend cupcakes, comma, lobster, and water. So, for example, in the and, we use in the last item we only use and, no comma, but before that each item should be separated from the other by comma. But in some cases with the fanboys, we do not use comma if we are connecting only two words. For example, the party feature cupcake and lobster, because it's only two words, no need for comma. And if we are connecting verbs or nouns phrases, for example, we can order food or stay in our budget. So we are connecting here two verbs, order and stay. The second type of conjunction is the subordinating conjunction. In this type of conjunction, we use the subordinating words to connect one dependent clause, and the second one is independent. So to make a complex sentence. So the complex sentence consists of one independent and one dependent clause. And we can, as a subordinating word that we can use it for this type of sentence is, for example, when, while, as, although, since, before, because, although, and even though. You should always remember that any of these words, if you see any one of these words in a sentence, that automatically makes this sentence a dependent and dependent clause. So if you see any one of these words, there is many other words, but these are only examples. But if you see any one of these words, that make it a dependent clause. So that means we need another independent clause to complete the idea. And also remember always to use the comma if you start the sentence with one of these subordinating words. Okay, let's see the examples. Even though he is talking about grammar, as you can see here, this is a dependent clause, because what is the meaning of that? Even so he's talking about grammar. What next? We need another independent clause to finish the idea. So here we will we'll put comma, and then to put the other independent clause, I'm still confused. Now there is a full idea. See, even so he's talking about grammar, I'm still confused. But also be careful if this subordinating word come in the middle of the sentence, there is no need for comma. For example, see here, I'm still confused because he is talking about grammar. Here we did not use the comma because the subordinating word come in the middle. Okay. The third type of conjunction is conjunctive adverbs. In this type, we use these adverbs to connect two independent clauses to make a compound sentence, also like the first one, coordinating conjunction. But here we are only connecting the ideas between the two clauses. We are not actually combining the sentence. It's like a way to start a new sentence, and each sentence will be like separate, but the idea is conjugated. For example, let's see some examples. I understand you. Sorry, we need to know what are these adverbs. We always can remember it with this word, hot, shop, cat, which include however and otherwise, therefore, similarly, hence, on the other hand, well, consequently, also, and then. There is others, but these are, you can memorize this first. Okay, let's see example. I understand you, however, I do not agree with you. If we look at this example, I understand you is a complete sentence with a verb and subject and idea, a complete idea, can stand alone. And I do not agree with you is also a complete one. So we use however to connect them, to connect the idea and to start a new sentence between. And we have two ways to use these adverbs. The first one, we can use the semicolon to separate between the two clauses, as you can see here in the first example. And in this case, the adverbs should start with a lowercase letter, as we can see here in this example. As the other way, we can separate the two clauses by the full stop or the period. And in this case, the adverbs should start with a capital letter. See the next example, I understand you, full stop. However, it starts with a capital H. Also, we can use a semicolon mark, which is like a comma with a dot above it, to combine two independent clauses without using a connecting word. We can see the example below. Dad is going bald, semicolon. His hair is getting thinner and thinner. But we should make sure that the connection between the two independent clauses are clear without a connector. So here he's going bald. How we know that? Because his hair is getting thinner and thinner. We can use only the semicolon in between without using any connecting word. And also the word after the semicolon should start with a lowercase letter. Okay, last thing, we said that we have a compound sentence and complex sentence. As compound, it connects two independent, and the complex connect one independent with one independent. Also, we have compound complex sentence. Let's see this example. Let's say, although he prefers watching romantic films, this is a dependent clause because there is no, it cannot stand by itself. So he prefers watching romantic film. So what come next? We can put comma. He rented the last spy thriller. It's complete. It's an independent one. It can stand alone. And then we connected with another one, and he enjoyed it very much. It's also an independent one. So when we connect two independent with one dependent, this make it a compound complex sentence. Okay, and that's it about connecting the sentence. Does anyone have any question?
Thank you very much, Dr. Omar. I think no question. We can go through the
Thank you very
agenda.
much. Okay, thank you.
Thank you both, Maarib and Dr. Omar, for the great presentation. Is still going on?
Yeah. Yeah, this brings us to the last topic in the agenda, which is updates about topics, about projects, and the agenda of the next week. If someone have an update, you can share it with us. Or if someone have a comment or question, please go ahead. Or Dr. Nader, you can go through the agenda for the next week.
So I'd like to thank all the fellows who attended the meeting and all the presenters today. And thank you so much, Dr. Maarib, for continue to hold the meeting. And thank you, Dr. Ammy. Although you're sick, you presented as well. So for next agenda, let's see, we have different topics, and So I put the names on the 4 agenda items for next week. So I see some of you are still present in the meeting, like Hina, Islam, maybe Ragda. If you can talk between you guys and your team. I don't see Mazin, and I think he is still the team leader. If he is not, maybe you can talk to the team leader. You can divide the task. I put your names in different items. If you like to present that item, that's well and good. If you like to present a different item from the list, you can move your name in the app. You can look at all the information there. There are some supporting document or resources that you can use, or you can use your own.
Thank you, Dr. Nadir. We're gonna have a meeting, and we'll arrange all the topics, and we'll have everything prepared for you next Saturday.
Perfect. Sounds good. Thank you so much. If you have questions, let me know, and I'd like to thank every one of you, and I wish you all the best. I hope you enjoyed the meeting and learned something. Thank you again for the presenters, and hopefully we will see you next week.
All right.
Thank you. Have a beautiful night.
Thank you so much.
Thank you so much.
Thank you.
Thank you so much.
Thank you, everyone. Thank you.
Thank you so
Thank
much.
you, Dr. Nadir.
Thank you.
Thank
Bye.
you so much.
Great.
Dr. Nadia. Thank you, everyone.
Everybody. Thank you so much.
You're welcome. Thanks.
Assalamu alaikum, Dr. Nadir.
Alaikum salam wa rahmatullah. Shema.
Thank you, Dr. Nadia, for everything. Thank you.
You're welcome.
Thank you so much. Have a
Anytime.
nice rest of the day.
Thank you.
so much, Dr. Nadir.
Yeah, thanks.
Thank you, Dr. Nadir. This is me here.
Oh, thank you, Mahir. Have a good one. See you later.
Thank you.
Thanks.
Thank you, Dr. Nadir. Have a good day, all of you.
Maarib, you had a question before we start the meeting, or someone else?
Yeah, me. Yeah, I have
You
a
have
question.
minute, or you have to go? If you have to go, I understand.
No, I can I can stay, but I think about the others, and but if someone can stay and see the question and maybe helping in answering it. Okay, I can share my screen.
Yes.
Explain it. Yeah.
Sure. Go ahead.
Okay, thank you. Yeah, the question is about, okay, what is, no, the eras. Okay, sorry, I'm out right now. Sorry for this.
No, that's all right. So Maarib has some question about the supplemental form in ERAS for internal medicine. So she will show us the application. So
okay.
Go ahead.
Okay. Sorry.
Maybe from the group who are still present, do you have any idea about the supplemental form? Ammy, Asma, Amal. Amna.
Yeah.
Okay, go ahead.
Yeah, I can see. I can show you that in the ERAS, in this specialty. If you want to search by specialty, I think the supplemental form is not in all specialties. It's also only in neurology, dermatology, as I know, and internal medicine. So when I choose neurology, okay. Sorry.
All right.
sorry. Yes. Yeah. They I mean the yellow box. They said that select neurology programs may participate in the supplemental ERAS application. Please visit the supplemental ERAS application webpage for information, guidance, timeline, and resources. And when I click the supplemental ERAS, they give a form which involve questions. They said that it's optional. But my question is, should I fill it? Will it increase my chances in programs, or no need for it? If someone have an answer, please share with us your information.
Hello.
Hello, go ahead.
Hello.
Yep. So what I've came to know about this thing is like last year, my seniors filled the supplemental ERAS and it was introduced that year. So they told me that it depends whether if you have any like particular you see when you want to when you are very particular about some program, then you should definitely fill this application, because this application is like a supplemental one which gives you more chance to like tell more about yourself. It has 5 things which you have to fill. Like one is for geographical specifications if you have any, then second is if you want to like signal some programs, then they'll then you'll have a more chance that they'll see your CV. And then there is one more thing, there is a place where you share your experiences, like other than what you have already shared in your CV and your personal statement. So this is like a supplemental thing, additional thing to your usual application. So this will just give you more chance to tell more about yourself.
Oh, okay. Yeah, and it's supposed to increase the chances in
yeah, in some cases it do, but I'm not sure about like some of the people told me like when you signal a program that you are interested in their program, so when you don't signal others, so they might get to know that you particularly signaled one program and not theirs. So I don't know what's the impact of that, but I'm searching about it, if whether when we signal one program, the rest of the programs will come to know about it or not. So if I get any information, I'll let you know.
Okay, thank you so much.
No problem. My pleasure.
Thank you so much.
Hello, Maarib.
Yes, go
Sorry,
ahead.
Dr. Nader.
No,
just like Sophia said, yes, it increases your chances. I'm sorry, I have no idea about this supplemental application, but I have seen many videos on YouTube. So YouTube is very helpful. If you search the supplemental application, you'll find many information about this.
Okay.
Yeah, thank you.
Thank you.
Sounds good.
Thank you, Dr. Nader, for reminding me the question. I forget.
That's fine.
Thank you so much.
Thank you.
Thank you.
Thank you, everyone. Any other?
Thank you.
Anything that you need to discuss, guys?
No, Doctor. Thank you so much.
Yeah. Okay.
Appreciate your good help. Thank you.
Thank you, and I wish you all the best. And have a wonderful day or night. See you next week.
Thank you, Dr. Nader.
Thank you.
Dr. Nader.
Thank you. Assalamu alaikum.
Wa alaikum assalam.